So in this chapter, we'll be dealing with peripheral nerve injuries. So let's first start by knowing the structure of a peripheral nerve. It consists of masses of axis cylinders or axons. So you have many axons, each with a neurolemma tube. So an individual nerve fiber is enclosed in a collagen connective tissue known as endoneurium. So here you can see the axons, the individual nerve fibers, they are enclosed by endoneurium. A bundle of these nerve fibers are together bound by together they constitute a fasciculus, and that is bound by perineurium. So perineurium, it covers the nerve fasciculi, and all these multiple fascicles are then collectively ensheathed by a fibrous tissue sheath known as the epineurium. So individual nerves, they are covered by endoneurium. So individual lots of nerves, they constitute a fascicle. So a muscle fasciculus, it is covered by the perineurium, and all these fascicles together, they are covered by the epineurium. Okay, this constitutes a peripheral nerve. So the peripheral nerves are formed from nerves arising from the spinal cord. So there are 31 pairs of spinal nerves in the body. So each represents a segment of the spinal cord. So these, either through direct branching or through a network of nerves called a plexus, they give rise to peripheral nerves. So they are mixed nerves carrying motor, sensory and autonomous supply to the limbs. So motor innervation of the limb muscles, this is important for diagnosis of a nerve injury. So you need to ask yourself, what is the nerve supply of a particular muscle and what other muscles does that particular nerve supply? And also, what is the action of a muscle, and by what maneuver can one appreciate its action in isolation? See, because one single movement can be caused by different sets of muscles. So if you want to test one particular muscle and the nerve injury, you need to test an action in isolation. Okay. So sensory innervation of the limbs. So the area of hyperesthesia resulting from a nerve injury can be less than the area of skin innervated by that nerve because of sensory overlap. So a relatively small area supplied exclusively by a single nerve is called an autonomous zone. Okay, so it is found in all nerve injuries. So here you can see, whenever you are suspecting ulnar nerve injury, okay, so ulnar nerve. So ulnar nerve, it supplies this side, right? So the little finger. So the skin of the little finger here, that is innervated solely by the ulnar nerve. Then you have the radial nerve, okay? So the radial nerve, it supplies the thenar part, right? So if you put it like this, a little bit of the skin here on the dorsal surface, okay, nearby the thumb. So that is supplied entirely by the radial nerve, that is the autonomous zone. And then the median nerve, see again, you have this side being supplied by the ulnar nerve, so these two will be supplied by the median nerve. So this part, these are autonomous zones for the median nerve. So ulnar nerve, median nerve, and here you can find the radial nerve, okay, near the base of the thumb here. So anatomical features relevant to nerve injuries. So first you have to think about the relation to the surface. So superficially placed nerves are more prone to injury by external objects. So median nerve, it often gets cut by any piece of glass at the wrist. Then relation to the bone. So radial nerve injury can occur in fracture shaft of the humerus. So relation to fibrous septae. Some nerves, they pierce the fibrous septae along their course. They may get entrapped in these septae. So entrapment neuropathies. Relation to major vessels. So nerves in close relation to a major vessel, they run the risk of ligation during surgery or damage by an aneurysm. Then course in a confined space, especially in median nerve compression and carpal tunnel syndrome. Fixation at points along the course. So common peroneal nerve, it is kind of fixed around the neck of the fibula. So that is why any stretching of the sciatic nerve often leads to isolated damage to the common peroneal component of the sciatic nerve. Next, pathology. So first, nerve degeneration. The part of the neuron distal to the point of injury undergoes secondary or Wallerian degeneration. The proximal part undergoes primary or retrograde degeneration up to a single node. So if this is the cell body and this is the axon, and here there is an injury, so distal part undergoes Wallerian degeneration and the proximal part undergoes primary or retrograde degeneration up to a single nearby node. Next, nerve regeneration. As the regeneration begins, the axonal stump from the proximal segment, it grows distally, okay? And then if the endoneurial tube with its contained Schwann cells is intact, endoneurium with the cells is intact, the axonal sprout may readily pass along its primary course and re-innervate the end organ. The rate of recovery is 1 mm per day. The muscle nearest to the site of injury recovers first because of the motor march. So proximal distal regeneration of the nerve. So nerve innervates muscles from proximal to distal. If the endoneural tube is interrupted, so what happens is, if there is an interruption, what happens is there are lots of sprouts. They migrate aimlessly, these axonal sprouts, They migrate aimlessly throughout the damaged area into the epineurium, perineurial or adjacent tissues. They form an end neuroma or neuroma in continuity. Okay, so an end neuroma may form when the proximal end is widely separated from the distal end. So here, like this they go. You can have something like this, end neuroma in continuity. And then again, you can also have a side neuroma. It indicates a partial nerve cut. Then mechanism of injury. So what are the various mechanisms in which nerves can be injured? So you have direct injury such as a cut or a laceration, infection such as leprosy, and then mechanical injury such as compression, traction, etc., cooling and freezing, thermal injury, electrical injury, ischemic injury such as Volkmann's ischemia, and then toxic agents such as injection tetracycline and radiation for cancer treatment. Then we can move on to Seddon's classification of nerve injury. So you have three types of nerve injury. So neuropraxia, axonotmesis, and neurotmesis. So basically in neuropraxia, what happens is it is a physiological disruption of the conduction in a nerve fiber. There is no disturbance to the anatomy of the nerve. So it's only a physiological interruption and the nerve is anatomically normal. So there is no degeneration because the nerve is still anatomically normal. There is no neuroma formation and it recovers completely within 6 weeks. Axonotmesis, what happens is the axons are broken but the nerve is still intact. So because the axon is broken, the anatomy is disturbed. So proximal and distal degeneration will be there. There is a formation of neuroma in continuity and it recovers and there is a motor march as well. And then neurotmesis is very severe. The axons as well as the nerve, it is broken. So again there is proximal and distal degeneration. An end or side neuroma can form and the recovery is poor. Okay, so nerve repair is required in neurotmesis because spontaneous recovery is not possible. And diagnosis. So in case of a peripheral nerve injury, you kind of have to take good history. So you need to find out which nerve is affected, at what level it is affected, what is the cause, what type of nerve injury is it likely to be, and will it recover or not. So history, a patient, obviously he complains of inability to move a part of the limb. There is weakness and numbness, so sensory and motor loss. And the cause of the nerve injury may or may not be obvious. Sometimes it is obvious, like, median nerve being cut at the wrist by a glass shard. Okay, and sometimes nerve injury may occur during an operation as a result of stretching or direct injury. So again, you have to take history and ask about neurotoxic drug use such as quinine and tetracycline, and any medical disorders like leprosy and diabetes in the past or right now. So examination. So you have to look at the motor system, the sensory system, the autonomous system, all that. So looking at the attitude and deformity, so if there's a wrist drop, the wrist remains in palmar flexion due to the weakness of the dorsiflexus. So it is seen in radial nerve palsy. So wrist drop in radial nerve palsy, foot drop in common peroneal nerve palsy, winging of scapula in long thoracic nerve palsy. Okay, and claw hand. It is seen in ulnar nerve palsy. So it means hyperextension at the MCP and flexion at the proximal and distal interphalangeal joints. So this occurs due to paralysis of the lumbricals, which flex the MCP and extend the interphalangeal joints. Okay. So there is something called an ulnar paradox, which means clawing is more marked in low ulnar nerve palsy than in high ulnar nerve palsy. This is because in high ulnar nerve palsy, both the flexors of the fingers, that is profundus and superficialis, are also paralyzed. Okay, so in ulnar nerve palsy, only the medial two fingers develop clawing, whereas all the four fingers, they develop clawing in combined median and ulnar nerve palsies. So in ulnar nerve palsies, these two fingers, the medial two fingers develop clawing, in combined all four. Okay, so ape thumb deformity. So the thumb is in the same plane as the wrist. It occurs in opponent's pulses, muscle paralysis, and median nerve injury. And again, pointing index. So on asking the patient to make a fist, it is noticed that the index finger remains straight. So it is due to paralysis of both flexors. So flexor digitorum superficialis and the lateral half of the FTP, flexor digitorum profundus of the index finger, which occurs in median nerve palsy at a level proximal to the elbow. Okay. So policeman's tip deformity. Again, you see that in Erb's palsy, the arm hangs by the side. It is pronated, the forearm. Okay, so again, you can also look at the wasting of the muscles and also the skin. It becomes dry because there is no sweating because of involvement of the sympathetic nerves. See, one thing which you do need to remember is that sympathetic fibers are the most resistant to mechanical trauma. The presence of sweating within an autonomous zone, it kind of reassures you that the sympathetic function is not lost. That is, complete interruption of the nerve has not taken place. So what you can do is use some starch or ninhydrin So dust the autonomous zone with starch or anhydrine, and these agents, they change color in coming in contact with squid. So again, you can also test temperature, because again, sympathetic maintenance of the temperature is lost. So that is why, because of loss of sweating as well, the paralyzed part is colder and drier. Okay, you can compare it with normal skin. And again, sensory examination. So you need to test the touch, pain, temperature, sensation, etc., and all the reflexes as well. So in axillary nerve damage, again, deltoid is paralyzed, right? So you have a flat shoulder, median nerve, thenar eminence, hypothenar eminence, ulnar nerve, hollowing between the metacarpals, the intraossei, you have again ulnar nerve, thigh wasting by the femoral nerve, and calf wasting, sciatic nerve. Okay, so again, you need to do a motor examination, and that is how you identify which nerve is injured. So now let's discuss the radial nerve. So anatomy, it is a continuation of the posterior cord of the brachial plexus, and in the axilla, see, the radial nerve, you need to remember that it supplies the triceps mainly. So okay, so first you have the long head, then the medial head, like this, okay, long head, then in the spiral groove the medial head and the lateral head. Okay, so it goes laterally and pierces the lateral intermuscular septum, right? So like that. So first in the axilla, it gives off a branch to the long head of the triceps and enters the arm. So in the arm, what happens is it gives off the posterior cutaneous nerve of the arm and a branch to the medial head of the triceps. Then it now travels infralaterally in the groove for the radial nerve on the posterior surface of the humerus in the spiral groove, winding spirally around the bone. And in the groove, it gives branches to the lateral head of the triceps and the anconeus muscles, and cutaneous branches to the arm and forearm. After winding around the humerus, it pierces the lateral intermuscular septum from behind at the junction of the middle and lower third of the arms at the level of insertion of carcobrachialis. So in the distal third of the arm, so between the brachialis muscle on the medial side and brachioradialis, so basically here you have on the radial side brachioradialis. It's a flat muscle, if you remember the dissection you did during anatomy. So you have brachialis and brachioradialis, right? So it lies between them. So it between the brachialis muscle on the medial side. So you have brachialis muscle, and then brachioradialis and extensor carpi radialis longus on the lateral side. Okay. So brachialis between that and brachioradialis and extensor carpi radialis longus, so ECRL on the lateral side. So before it crosses the elbow in front of the lateral condyle, it divides into two branches. So superficial and deep. Superficial is sensory, S for S. Okay, it travels along the side of the radial artery into the forearm. The deep branch is primarily motor. So it gives branches to the extensor carpi radialis brevis and the supinator. Then it pierces the supinator and emerges in the posterior compartment of the forearm to become the pin nerve, so posterior interosseous nerve. So it supplies the extensor muscles of the forearm. So again, before it enters the radial groove, it gives branches to the long and medial heads of the triceps. After entering the radial groove, within the groove, before crossing the elbow, it gives branches to the lateral head of the triceps and the anconeus muscles. Okay, just before crossing the elbow, again it gives branches to brachioradialis, ECRL. After crossing the elbow, before piercing the supinator, it gives branches to the supinator and the extensor carpi radialis brevis. Okay, after piercing the supinator, it becomes the pin nerve and supplies the other extensor muscles. So in high radial nerve palsy, if the nerve is injured in the radial groove, so the triceps has already been supplied. So triceps is saved, the heads of the triceps and also the anconeus. So other than these two muscles, all the other muscles supplied by the radial nerve are paralyzed. So still higher up, even the triceps may be paralyzed, and that is called very high radial nerve palsy. In low radial nerve palsy, it occurs if the nerve is injured around the elbow. So other than the muscles which are supplied in the elbow, so brachioradialis, extensor carpi radialis, longus and brevis, so these muscles are spared, and the rest of the muscles supplied by the radial nerve are injured, are paralyzed. So from proximal to distal, you can examine these muscles. So triceps. So what does triceps do? It extends the arm. It extends the elbow, right? So extension. So basically what you can do is, you provide resistance and feel the triceps contraction. Then brachioradialis. So brachioradialis, it is located on the lateral side, right? So you ask the patient to flex the elbow from 90 degrees onwards, keeping the forearm midbone. So like this, you try to keep the forearm mid prone. Okay, this is prone. Okay, keep it mid prone and try to flex it, and you can see the contraction of the extensor carpi radialis. You can see the contraction of the brachioradialis, especially against resistance. Okay, so triceps extend the forearm. Okay, and also brachioradialis, flex the elbow like this, and then keep the forearm mid prone, and you can feel it, the brachioradialis. Next, wrist extensors. The patient with paralyzed wrist extensors has wrist drop. So radial nerve, again you have wrist drop. So in case the paralysis is partial, the extensor carpi radialis and the extensor carpi ulnaris muscle, the contraction can be felt even though the movement does not occur. So extensor digitorum, so it causes extension at the MCP. Okay, so if that is not there, then there is finger drop. So wrist drop and finger drop are seen in radial nerve palsy. So basically, interphalangeal joints extension is done by lumbricals, so don't confuse this. So extension needs to happen at the metacarpophalangeal joints, and that is radial nerve function. So extensor pollicis longus. So what happens is this causes extension at the interphalangeal joint of the thumb. So first stabilize the metacarpophalangeal joint of the thumb and try to extend the interphalangeal joint against resistance. Then median nerve. So it is formed by the joining of branches from the lateral and medial cords of the brachial plexus. So the nerve enters the forearm between two heads of the pronator teres. Then it passes, then you have this tendinous bridge of the flexor digitorum superficialis muscle. So it passes beneath that. And then in the mid forearm, it descends between flexor digitorum superficialis above. So it goes like this, if this is the dome of the flexor digitorum superficialis. So and it is above the flexor digitorum profundus. So between the superficialis and the profundus, it descends. And at 5 centimeters above the wrist, it comes to lie on the lateral side of the flexor digitorum superficialis. Then it becomes just superficial above the wrist, where it lies between the tendons of the superficialis and the flexor carpi radialis. So course in the hand. So the nerve passes deep to the flexor retinaculum and enters the palm. That is why, because it passes deep to the flexor retinaculum, it is involved in carpal tunnel syndrome. Here a short and stout muscular branch from it supplies the muscles of the thenar eminence. So abductor pollicis brevis, opponens pollicis, and flexor pollicis brevis. So the median nerve finally divides into 4 to 5 palmar distal branches, and again motor branches to the lumbricals, especially the first and second lumbricals. So basically, in the arm, it doesn't give any branches. In the proximal forearm, it innervates all the flexor muscles except flexor carpi ulnaris and ulnar half of the flexor digitorum profundus. In the hand, again thenar muscles and first two lumbricals. So tests. So in high median nerve palsy, injury is proximal to the elbow. So again, this will cause paralysis of all the muscles supplied by the median nerve in the forearm and the hand, and there will be sensory deficit in the skin of the hand. Low median nerve palsy, especially in the distal third of the forearm muscles will be spared, but the muscles of the hand, especially thenar muscles, will be paralyzed. So in addition, there will be anesthesia over the median nerve distribution in the hand. So we talked about the autonomous zones, these two fingers, okay, these two regions. Next, from proximal to distal, so flexor pollicis longus. So you can flex the terminal phalanx of the thumb against resistance while the proximal phalanx is kept steady by the examiner. So try to flex this, okay. Keep this steady and try to flex this. Then flexor digitorum superficialis and lateral half of flexor digitorum profundus. So try to clasp the hand, okay. The index finger will remain straight. This is called the pointing index. This occurs because both the finger flexor superficialis and the profundus are paralyzed. Through the available medial half of the flexor digitorum profundus, the flexion of the other fingers is possible. Okay, so flexor carpi radialis. So normally the palmar flexion at the wrist occurs in the long axis. So again, if there is in a patient with paralyzed flexor carpi radialis, the wrist deviates to the ulnar side. So radial side is paralyzed, so ulnar side deviation will be there. And this happens especially when palmar flexion occurs, okay. And in addition, one cannot feel the tendon of the flexor carpi radialis getting taut. And then again, muscles of the thenar eminence. Only 2 can be examined out of the 3. So first, abductor pollicis brevis. So basically, abductor, it abducts at right angles to the palm. Alright, so put a pen at right angle to the palm. Put your hand on hand like this on a flat surface and try to touch the pen, okay. that is called the pen test. And then for the opponent's policies, you try to oppose. It is a swinging movement wherein the thumb touches other fingers. It is not adduction, it is a swinging movement. So you can touch opponent's policies. The ulnar nerve, it arises from the medial cord of the brachial plexus. It lies on the medial side of the axillary artery in the arm. So at the junction of the middle and lower third of the arm, it pierces the medial intermuscular septum and lies in the posterior compartment. So then it becomes more and more superficial, where it lies just behind the medial epicondyle. So if this is the posterior aspect of the humerus, this is the medial side, there's a groove for the ulnar nerve, right? So that is why when you hit your humerus, the distal end, you feel a funny sensation. So humerus is called funny bone. So that is why it lies just behind the medial epicondyle. Then it enters the forearm between two heads of the flexor carpi ulnaris on the ulnar side. The ulnar nerve descends along the medial side of the forearm. Here it lies anterior to the flexor digitorum profundus, obviously, along with the ulnar vessels. So course in the wrist, so it passes in front of the flexor retinaculum. It does not pass beneath it. So that is why it is not involved in carpal tunnel syndrome. So on entering the palm, it divides into superficial and deep terminal branches and supplies the hand muscles. So in the arm, no branches. In the forearm, so in the proximal part, it supplies the flexor carpi ulnaris. Medial half of the flexor digitorum profundus, it passes through near those muscles. So distal 1/3, no supply again. In the hand, again it's the superficial branch, it supplies the hypothenar muscles, okay, so on this side, and the deep branch, it supplies the adductor pollicis, okay, and then all the intraossei and the medial two lumbricals, okay. So what are the various tests? So in high ulnar nerve palsy, injury is proximal to the elbow. So all the muscles supplied by the ulnar nerve in the forearm and in the hand will be paralyzed. So there will be a sensory deficit in the skin of the hand. So low ulnar nerve palsy, there will be sparing of forearm muscles, but the muscles of the hand will be paralyzed. And the sensory deficit will be the same as in high ulnar nerve palsy. And individual muscles which you will be testing are flexor carpi ulnaris. So basically you will ask the patient to palmar flex the wrist against gravity, and there will be a radial tilt, okay. So the hand deviates towards the radial side. So the tendon also of the flexor carpi ulnaris, it does not stand out. On performing it against resistance, the tendon cannot be felt. Next, abductor digiti minimi. So the patient is asked to abduct the little finger against resistance, okay, against resistance. So while keeping the hand flat on the table, okay, so keep the hand flat and try to abduct the little finger. Next, interossei. So pad and dab, remember this. So pad, palmar interossei do adduction and dorsal interossei do abduction, okay, at the MCP, at the metacarpophalangeal joints. So you have something called the Igawa test. So basically you place your hand flat, okay, on the surface, and then you try to move the middle finger, okay, sideways. So that is the Igawa test, okay. This is for dorsal interossei, abductors of the middle finger. Then the card test is for palmar interossei, adductors of the fingers. So basically you put a card between the fingers and try to pull the card, okay. So if the adductors are strong enough, they'll hold the card in place. Next, lumbricals. So basically you can't test them in isolation, but they're responsible for flexion at the MCP. Next, adductor pollicis. So basically what you'll do is you'll ask the patient to grasp a book, okay, in between the thumb and the rest of the hand. So basically in a normal person, he'll use full extension to hold the book, whereas in if the adductor pollicis is, you know, paralyzed, what he'll do is he'll try to hold it like this, okay. Especially when you try to pull the book away, this motion is exaggerated, okay. So basically this produces flexion at the interphalangeal joint because he tries to use the flexor pollicis longus in place of the adductor pollicis. Then accessory nerve, so it supplies the trapezius muscle. So basically you ask the patient to elevate his shoulder against resistance, and then one can see the trapezius belly stand out, okay. And then long thoracic nerve, again C5, C6, C7. So it descends on the lateral surface of the serratus anterior muscle. So again, it causes swinging of the scapula if this nerve is injured. So here you ask the patient to push against a wall with both hands, and you'll see winging of the scapula. Next, axillary nerve. So it arises from the posterior cord of the brachial plexus. It curves backwards on the lower border of the subscapularis muscle, crosses the quadrangular space, and lies on the medial side of the surgical neck of the humerus. divides into anterior and posterior branches. So posterior branch, it supplies teres minor and posterior part of the deltoid, and also it gives sensory supply. The next anterior half, it again supplies the rest of the deltoid. So this you try to test the deltoid muscle, you abduct the shoulder, okay. Then inability, it suggests deltoid paralysis, and also you try to palpate for the muscle belly of the deltoid. Then sciatic nerve, so it consists of two components, the tibial and the common peroneal components. So common peroneal is frequently affected, so you'll have a typical high stepping gait in common peroneal nerve palsy, and you'll also have foot drop, okay. And then in tibial nerve, it supplies the plantar flexors of the foot. So again, you ask the patient to plantar flex the ankle and the toes, okay. And function of the hamstring group of muscles also, it can be tested by flexing the knee against resistance. So the hamstrings, they kind of flex your knee, right? So that also you can test. Next, the causes of injury. So again, you must look at which level the muscle is, the nerve is injured, and then again, how it is injured, the mechanism. Is it because of a glass shard or any other thing? Medical causes. And then once the cause of the nerve injury is established, you need to evaluate the predominant type by Seddon's classification. And then signs of regeneration also you can check. So basically during examination, what you see is the Tinel's sign. So distal to proximal, you gently tap over the nerve along its course, and you'll feel a pin and needle sensation in the area of skin supplied by the nerve. So a distal progression of the level, it suggests regeneration. Next, motor examination again. The muscle supplied nearest to the site of injury is the first to recover. Okay, so this is the motor march. This phenomenon is absent in neuropraxia, where all the muscles recover together. Next, electrodiagnostic tests, they help in predicting the nerve recovery even before it is apparent clinically. So electrodiagnostic studies, so let's first discuss electromyography. So EMG is a graphic recording of the electrical activity of a muscle at rest and during activity. So normal muscle at rest, it shows no electrical activity, but with voluntary contraction, action potentials, they develop in the motor units. So in a weak contraction, they may be recordable as a single motor unit potential in the vicinity of the recording electrode. So little activity, single motor unit potentials can be recorded, but in full activity, all impulses of a number of motor units fire simultaneously and they are superimposed. So this gives rise to an interference pattern on full activity. Then you have something called denervation potential. So when there is a denervated muscle, it has spontaneous electrical activity at rest. Okay, they represent embryonic electrical activity of the muscle, which is normally suppressed by stronger nerve action potentials. So these appear around 15 to 20 days after the muscle denervation. So as the nerve degeneration progresses, more and more degeneration potentials appear. If the degeneration potential has not appeared by the end of second week after a nerve injury, then it is a good prognostic sign. It means degeneration is not there. Okay. So EMG is useful in deciding whether or not a nerve injury is present. Okay, the pattern is different, and whether it is a complete or incomplete nerve injury. So in incomplete nerve injury, you'll have residual innervation of the muscles. It is too small, the signal, but you can still pick it up on an EMG. But in complete nerve injury, again, you'll have, denervation potentials and all that. And again, whether any regeneration is occurring, so reinnervation potentials, you can find them on an EMG. And level of nerve injury, so you can check where the which muscle, the signal is strong and weak and all that. By performing an EMG of all the muscles supplied by a nerve, you can find the level of nerve injury. Then you can check the strength duration curve. So it's a graphic representation of the excitability of a muscle and a nerve tissue under rest. So small strength of current is enough to excite a normal muscle. This occurs by excitation of the muscle through the neuromuscular junction. So NMJ needs a weaker current, but in a denervated muscle, to excite the muscle, okay, you need to directly stimulate it with a higher strength of current. So a very low strength current is given for a duration of 300 milliseconds and its response is noted. Okay, so the minimal current strength required to elicit muscle contraction is called the Rio base. It is measured in milliamperes. And the chronaxy, when you use double the Rio base, the time required for muscle contraction is chronaxy. Okay, so it is measured in milliseconds. So these two are the basic parameters of excitability of a muscle. So basically, you'll take a muscle and you'll do strength duration curve. Okay, and you have three things to interpret here. So in a normal strength duration curve, The normal muscle will respond to stimuli varying duration from 300 milliseconds to even as low as 3 or even 1 millisecond without any increase in the strength of the current. If the duration of the current is increased, a progressive increase in the strength of the current is also required to produce a contraction. So this is the normal curve, okay? This is the nerve curve, okay? Because the muscle contraction is caused by stimulation of the motor nerve, the NMJ, entering the muscle. In a denervated muscle, so a totally denervated muscle will need current of more strength for a longer duration. So it is called a muscle curve, okay? And in between them, you have something called a partial denervation curve. So partially denervated muscle. So it shows features of both nerve curve and muscle curve. And there is a kink where the two curves intersect, okay? So assessment of recovery by the strength duration curve. So on serial examination, the curve is supposed to get flatter with a shift to the left, to the normal curve, okay? Nerve curve. So nerve conduction studies. It is a measure of velocity of conduction of impulse in a nerve. So a stimulating electrode is applied over a point in the nerve trunk and the response is picked up by an electrode at a distance or directly over the muscle. Okay, so the normal... So the velocity of the conduction of the impulse between any 2 points of the nerve can be calculated, and normal is around 70 meters per second for a motor nerve. So nerve conduction studies will tell you whether or not an injury is present, whether it's a complete or partial nerve injury, and whether it's a compressive lesion also, especially in carpal tunnel syndrome, etc. So treatment first, arterial bone and joint repair takes precedence over nerve repair, okay? So it can be conservative or operative. So first, you can do splintage of the paralyzed limb in conservative treatment. Okay, so you splint the limb, which will relax all the affected muscles. Okay, we already talked about various splints. Then you can preserve the mobility of the joints. Okay, so full range of motion at least once every day. So care of the skin and nails. So since the skin is anesthetic, so it should be protected from trauma, so pressure sores, all that. Trophic ulcers should be treated, and again physiotherapy and relief of pain. Operative treatment. So first you have primary nerve repair. It is indicated when the nerve is cut by a sharp object and the patient presents early. Okay, so basically you need to suture both the cut ends. So you can use fine silk sutures. So sometimes what some surgeons do is they do a delayed primary repair because they feel that the epineurium, it gets thickened in 2 weeks and the sutures will hold better. So secondary repair is indicated for the following cases. So when nerve lesions present sometime after injury, when there is a syndrome of incomplete interruption, so if there is no definitive improvement in 6 weeks, so then you do a secondary repair. Syndrome of irritation, so nerve irritation, and failure of conservative treatment within 3 weeks, okay? And then techniques of nerve repair. So nerve suturing, what you can do is you can do an epineural suture of both the nerves. You can do an epiperineural suture, okay? So epiperineural suture. You can do a direct perineural suture, and you can also do nerve grafting, so we'll discuss that. You can also do a group fascicular repair. Alright, so sometimes the loss of nerve tissue is so much that an end-to-end suture cannot be obtained. So what do? So you try to mobilize the nerve on both sides of the lesion. Then you try to relax the nerve by temporarily positioning the joints in a favorable position. And then you alter the course of the nerve. You sacrifice some unnecessary branches. And then you strip the branches from the parent nerve without tearing them. Nerve grafting. So if the nerve gap is more than 10 centimeters or an end-to-end suture is likely to result in tension at the suture line, so nerve grafting may be done. So in this, an expendable nerve such as a sural nerve is taken and sutured between the two ends of the original nerve. Next, neurolysis. So basically when there is a scar and you try to free the nerve from it, that is neurolysis, okay? So external neurolysis is when there is perineural fibrosis. So when there is intraneural fibrosis, you do an internal neurolysis, okay? So you dissect the nerve sheath longitudinally to relieve the pressure from the fibrous tissue within the nerve. Then reconstructive surgery. So these are operations performed when there is no hope of the recovery of a nerve, usually after 18 months. Okay, so operations include tendon transfers, arthrodesis, and muscle transfer. Rarely amputation is also justified. So decision making. So basically you do electronic diagnostic tests. So and then you basically decide whether or not you need to operate and all that. So prognosis, again, the lower the age, the better the prognosis. So it also the prognosis is dependent on the tension at the suture line, time since injury, location of the injury. The more proximal the injury, the worse is the prognosis, because a lot of degeneration and regeneration needs to occur. And then the type of nerve. So primarily a motor nerve like a radial nerve has better prognosis than a mixed nerve. Condition of the nerve ends, and again associated conditions, so they also affect. And you need to remember this treatment plan. So when a nerve is injured, if the nature of the lesion is not known, directly go for electrical studies. If the nature is known, and if the nerve is not in continuity, go for repair and allow the reinnervation to take place. If the nerve is in continuity, wait for 3 weeks, see if it recovers, and then you examine for return of activity. Okay, if there is no recovery, you go for electrical studies. Okay, you do all this. And if recovery occurs, you follow up every 1 to 3 months, and progressive recovery and full recovery, okay, it is good. If there is no progress, again you go for electrical studies. And when you go for electrical studies, you have to consider surgical repair, and then you keep on monitoring the patient.